Well, welcome to this week's episode of The Dental Guys. I'm Wes, the Dental Guy.
And I'm John, the Dental Guy. And Wes, here we are, ready to bring it once again. But
Super excited about this week's episode. This week's episode is brought to you by, been around for a long time sponsors of the Dental Guys, the Dental Crafters
sponsor.
Network. OG sponsor, back with us. So glad the Dental Crafters Network is sponsoring the Dental Guys this year. Unlock the potential, John, of one relationship with the Dental Crafters Network where possibilities are truly infinite. As a family-owned, full-service laboratory, they collaborate closely with dentists to understand and meet their unique needs in today's ever-changing dental industry. And is it ever-changing, man? Choose the Dental Crafters Network, where your vision meets innovation. And here's the kicker, John. Here's the kicker. Let me just say this. If you visit the dentalcraftersnetwork.com, actually it's .net. Let's get that right.
Yeah,
visit
dentalcrafters.net.
Visit dentalcrafters.net. Listen, there for our people, right, that are listening to this show, right, you can get 10% off your first case, right? And that would be amazing, right? Just mention the Dental Guys. This is what helps us out, guys. And we appreciate the Dental Crafters Network and their support of our show. John, what's coming tonight?
Well, here we are about to get our final arrangements together for traveling to the Academy of Osseointegration 2024 meeting, which is in Charlotte, North Carolina. It's kind of crazy. This is the closest it's ever been to us in our backyard. So we're super, super excited to be back at the Academy of Osseointegration meeting. And what's interesting about our relationship, Wes, with Academy of Osseointegration goes back to before they even knew there was a relationship. I kind of joke about that because we were going to this meeting. I've been going since 2008. And as we started going together to these meetings,
we were tweeting and tagging them or Xing them. I don't know what you say now.
I know. Whatever it was, we were doing it. And at the end of the show, we were recording our own show at the AO as a recap. And eventually we were able to form a strong relationship with them and partner with them to be able to release some amazing content. And here we are about to go back again. And by the way, if you haven't registered for this meeting, now by the time this releases, it's getting close.
Yeah, you better get on it.
Get on it and go to osseo.org, and March 7th through the 9th, 2024, Charlotte, North Carolina, get registered because some of the top names in implant dentistry will be there. But we wanted to prepare our listeners for what's coming. We decided to go into the archive of the last Academy meeting that we were at, that we have a privilege to be at. We had this amazing setup there. Amazing booth setup. Thanks a lot to the crew that helped us out with all of that. We're going to have another one very similar this time. And we pulled out some of the content that messed with us. I think it's going to be a phrase of the year, Wes. It's been things that are messing with us. And these are topics and speakers that have changed the way we think about things. And we had the opportunity to interview them. So Wes, talk a little bit about maybe a little bit of a preview. What are our listeners going to get to hear from the archives today?
This is a good one, John. One of my favorite interviews of all time is what you guys are getting ready to listen to. For years, we've talked about, what to do whenever we take a tooth out. Do we put an implant in? And when we do put an implant in, immediate extraction, immediate placement, how do we manage the socket? So John and I, at our request, we wanted to put Howie Gluckman up with Dennis Tarnow and have a point-counterpoint conversation regarding how we manage the socket. Dr. Tarnow, who has coined dual zone technique in the literature, you'll see it, and we'll talk about that in this episode, and he'll discuss why he uses that. And then also Dr. Gluckman, who discusses socket shield, right, or partial extraction therapy. And we ask questions that you guys might want to know, the answers to in this. And I hope that you have the opportunity to watch this on YouTube, because the way that these two clinicians explain things can be really seen in the passion that they put into their explanations, right down to there's a point where Dr. Tarnow uses a cup with water in it and one of our business cards to describe the shield and the bone and all these things. There's also times where they disagree and where times they agree. And after this, John and I are going to come back after you guys listen to this back and forth between them. And we're going to have a few comments, so stay tuned for that. So I'm super excited about this tonight. Dennis Tarnow and Dr. Gluckman on socket shield versus dual zone.
And we have two excellent clinicians and researchers, and Dr. Dennis Tarnow and Dr. Howie Gluckman here. Thanks for being with us. Really appreciate you guys being here.
Thanks.
Thank you.
Thanks for having us.
We are we've been kind of planning this show for a while because we know that there's some great discussion to be had about one of the most interesting topics that has been discussed for years and years, which is how to manage the immediate extraction socket with an implant. What do we do once the tooth has been removed, or do we remove the whole tooth? And what do we do with the gap? And what do we do? How do we manage the soft tissue? And our goal, of course, is to minimize changes. And we know both of you have been heavily involved for years and years in this area of research and clinic. So I think maybe the easiest way to kind of get people calibrated, what we're going to talk about, is most of you watching this or listening know when we mention the word dual zone technique and socket shield or partial extraction therapy, know what we're talking about. But for those of you who don't, let's maybe quickly summarize what that means. And Wes, I'll let you do the quick summary, and then we're going to ask the questions we think everyone wants to have the answers to.
Well, let's start with dual zone. First of all, the tooth is extracted, and once the implant is in place, if you place it properly, there should be quite a bit of a gap between the implant and the bone and soft tissue. And zone 1 grafting, John, would be a grafted allograft, up to the top of bone. And then the second zone is the soft tissue zone, but we're grafting that with bone. And as Dr. Tarnow published, that zone of grafting does help to thicken soft tissue, over time if it's managed volumetrically. And then on the other side of the table, we have a technique where most of the tooth is really not extracted, but the tooth has been shaped, and there's a remaining shape of the tooth that's left as a shield, per se, to shield volumetric change from muscle.
Yeah, to try to maintain the bundle bone.
That's right.
And so as we talk about these techniques, many of the questions that we start to have are, well, which technique works the best? Which is the most validated? And then that's everybody wants to know what's the best, right? But maybe it's what's the most appropriate for the situation or the case. And then also we want to talk a little bit about, what's the most teachable and the most achievable for most clinicians. And so let's talk about that. Maybe we start with you, Dr. Gluckman. What do you talk about the technique comparison and, your thoughts on what works where and when, and how do we make some of these decisions? And Dr. Tarnow, we'd love to hear the same from you.
Sure.
I think I will start by saying that my journey started with dual zone therapy many years ago. And I think one of the problems that I had with the dual zone therapy is that over the long term, things started to collapse on me. And I didn't get things as well as I wanted to. And socket shield answered some of those questions for me. And it is not a simple technique. It is certainly a reproducible technique, and it certainly is a teachable technique. But it started to give me something which I feel was a little bit more biological than other techniques, because of the fact that this piece of tooth prevented the bundle bone from disappearing in any way or in any shape or form, whether it was thin or whether it was thick. But saying all that, there's still a time and a place for everything. And I think each technique has to be, you have to choose each technique specifically. There's certain parameters that the socket shield requires, and you need to make sure that you follow the right guidelines to do them. If that doesn't work, dual zone therapy, well, for me, with a soft tissue graft would be my go-to. But I think it's a horses for courses kind of approach that one has to take. And to coin a phrase, I think it's each technique is something that it just gives you another option. If all you have is a hammer, then everything looks like a nail. and you want to have multiple tools in your armamentarium to make sure that you can give the patient the best for that for their thing.
So on the counterpoint, Dr. Tarnow, do we need, as clinicians, the armamentarium of the socket shield to achieve the therapy we need for immediate extraction, immediate placement, or is dual zone enough?
Well, I've been using dual zone now for about, I guess, 9 to 10 years in a private practice. And initially we weren't doing immediates because we weren't sure about the healing of the gap. And we'll talk about the healing of the gap with either technique. I think that's important. And what the graft does or not does and the gap size. But that was a controversy because people said that if you have a gap distance between the bone and the implant of initially greater than 1.5 to 2 millimeters, almost everybody said the same thing. From research as far back as 1988 has shown us on animals. Akimoto and Becker did this also. So there's about 6 or 7 articles that held me back from doing immediate sockets because what happens if I had a 2 millimeter gap? Then I would have a fibrous seam next to the implant. In other words, I wouldn't have, without a socket shield. I'm talking about if I had a buccal bone, but I didn't leave a piece of tooth in there, I would have a gap sometimes greater than 1.5 or 1 millimeter. And so I didn't want to have a fibrous seam between the implant and my buccal bone. So the concept being that if I had a fibrous seam, I could get future peri-implantitis and it could unzip on me right down the front. It wasn't bone up against the front of my implant. And then I realized when I went back into that literature, I realized there was a flaw to that research. They all did one thing thinking it was okay. They put the implants in with the different size gaps, and then they put the flap over the top. And they did primary closure without a membrane over it. So they put, here's the implant with a trough around it or a gap. They would put the flap of the animal, they pull it over the top. And then the fibrous tissue from the flap would be able to go right down. And that was faster than the bone coming across the gap.
Mm-hmm.
And that's why all the research was valid, but that's if you do primary closure. If you do secondary intention healing, which is what we do, no flap, leave the tissue exactly where it is. When you open it up, then you have a gap distance, and that for the gap doesn't matter. The gap size doesn't matter. Bone will fill into any gap size, no matter what size it is. And that's a misnomer that people still think, 1.5 millimeters, you got to worry about, you don't want to get too large. That's ridiculous. We've learned that is incorrect, and that's only if you pull a flap over the top. So that's what allowed us to do. And that was about 10 years ago. And we realized that we were getting, and we published on this with one of our articles about 2014, that if we supported the tissue with the temporary, which is what we all will do, and if we filled the bone, not just up to the gap, but filled it supracrestally, the soft dual zone being the soft tissue zone, we found that our tissue was thicker when we had the healing, and we documented that and published on that. We actually measured those differences, and it was as much as 50% thicker when we did the grafting of all the way to the top of the free gingiva, and then put the temporary on at the same time. And that was our best results. And we published on that about 4 or 5 years ago. And so it's been a mainstay, and we haven't come back to hurt us. If something hurt us, we're in the middle of Manhattan, and we're in a pretty private, high-level private practice. And if it hurt us cosmetically, we wouldn't be doing it. If it hurt us 5 years later, we certainly wouldn't be doing it. So we haven't found, by placing the implant to the palate, filling the gap, and bringing it up to the top, that for us has been a real mainstay for our private practice, and it's been held up all these years.
So the feeling being that maybe that's so where I know we talked about, we had in your lecture this morning, you were showing some cases, and one that you showed that was maybe a little bit more extreme challenge was adjacent implants. For instance, an existing implant was there in a number 7 location. Patient was going to lose number 8. And, the question was, well, is dual zone enough for a case like that, for instance? Now that maybe that's an extreme situation.
I'm not sure that it is extreme. I think it's the reality, and I think it's something that we have to prepare for right now. And I think that's where for me, where things start to diverge, because there are certain times. One of the key factors with dual zone is that your buccopalatal dimension has to be wide enough to allow the jump gap size that you require to pack bone, so that the biology can take care of that bone and create new bone. There are a lot of cases where you don't have the buccopalatal dimension. In those cases, your implant is going to end up closer to the bundle bone that it would be, meaning that the chances that you're going to have no buccal bone over the implant is fairly high. The second thing, as you mentioned now, is that when one has a second implant, and I mean, and Dennis, you'll know better than anybody else, being so well published on that. The minute you put two implants next to each other, that bone is going to collapse. And interestingly enough, there's a new publication coming out from Joseph Kahn's group, where they actually measured implants next to each other and showed the maintenance of papillae with what I was showing this morning in the lecture, where for the first time we are getting phenomenal interproximal bone, and it's staying absolutely stable. It's not resorbing at all. And even when you have an old implant next to a new implant with a socket shield, it doesn't need to be two socket shields together. So I think with that kind of situation, if one can utilize that kind of forum, does it mean you should only use it for adjacent implants, etc.? Yes, if that's the way you want to work and dual zone is easier for you, I think you must use whatever works for you. I think that's important for us to say. I don't think we must push anything in any direction. For me, though, I think I want to make sure that should I have an implant next door, I have the option of maintaining that interproximal bone. And certainly, I don't see another technique that I can use that allows me to keep that interproximal bone the way socket shield does. And that's where I think maybe it really is something that's exceptional compared to some of the other techniques.
You know, we're
Let
talking
me just
about
comment on that.
Yeah.
Remember, they've got to differentiate, and I don't disagree with what Howard just said, for interproximal. So let's differentiate between interproximal and midfacial. I was talking strictly about midfacial when I had my discussion with you just now, that buccal gap. And interproximal, I know Joe's worked really well, and he's done a great job with this. And yes, he came out with, I think, almost 2013 using the interproximal support of socket shield, leaving it alone interproximally so it would stick out. What we're missing when we have two implants next to each other, as you know, is the supracrestal biologic width on something, preferably the tooth if it's healthy. So what Howard's recommending and what Joe was talking about, Joe Kahn, correctly is talking about let's keep the tooth in the interproximal area so that we have some fibers, some gingival fibers, which is supracrestal, there to support the papilla. And I don't disagree with that. And I think we got to do more research on it. But I think that Joe's on the right track and you're on the right track by saying let's at least, and you only need it on one tooth. You don't need it on both teeth. Just like a single tooth implant. If you have one tooth that's healthy and you put an implant next to it, the supracrestal fibers support the papilla from the natural tooth, because the biologic width on the natural tooth is supracrestal. And that's what's supporting the tissue. That's why everybody loves to show you single tooth implants. When you get to two, like Howard brings up, there's no question it would be great to leave a piece of it there, or a C shape, in the remaining piece if you leave the buccal, but you leave the interproximal piece also. Like when you, and this is just technique. Some people leave just the shield interproximally, but if you can leave the buccal and interproximal, then just leave more around, and you can accomplish that. So I think that's probably one of the major places where I think socket shield will really help is interproximal between two implants. I don't disagree with that at all. I agree with you 100% on that.
And I think this is amazing stuff, because here's what you're doing is you're rewriting what we are using in our clinics today, which is how much papilla can we generate right now. And based on your research, between an implant and a tooth, it's about 6.75 millimeters mean. And we know implant to implant, based on research published, it's much less than that, a millimeter and a half less than that in the 5 range. And that's mean. That means we could get less, we could get more based on phenotype and based on like the procedure that's done. And if we're going to rewrite Frank Spear's article on Pontics versus implants, I think that's where it comes into the next question, John, is how we talked a little bit about this in the pre-show per se, about the teachability of each of these techniques. And Dr. Gluckman, you said that in one of your articles regarding PET a few years back. I say a few years, but a few years was 2020, and it seems like I blinked and 2020, 2021 went by.
That's right.
But a few years back, you said at the end of the article that PET is a technique that is reserved for the right hands and at the highest level in settings where it needs to be researched, refined, and redesigned. Is it ready to be taught in a systemized way so that we can really get this out to the masses as a thing that can be repeatedly done consistently and predictability wise?
I think the simple answer to that is yes. There's no doubt about it. I think we have got to a stage, and that publication specifically was a publication where we had deconstructed the technique to such a degree that we could make it a reproducible technique. I really believe that, and I think it's just people might disagree. I strongly believe it. Having taught it, luckily enough, in many countries around the world, and having the feedback that I'm getting from people who have done a few techniques, and I think this is a key thing to remember, is that often we will try a technique. You'll read a technique, you'll try a technique, or you'll see a technique, and you'll fail 3 or 4 times before you start to get it right. Those are techniques that are not reproducible. There's something wrong either in the data or in what we're being taught. If you can pick up a technique whereby you can try it the first, second, third time and you get the same results that I'm getting, that's a truly reproducible technique. And I do believe that socket shield is one of those techniques. We had to deconstruct, we had to think about how we teach it, and teaching it over the years has allowed me to deconstruct in such a way that can allow people to do it. There's no doubt, though, that people need to be trained. And, you know, a lot of people are picking up the technique. They're not even reading the publications. They're kind of reading the abstract and like, oh, that looks good. Look at the pictures, you know, see one, do one.
That's dangerous.
And that's dangerous, you know what I mean? And I think I don't subscribe to that at all. And I think it's like anything else. Go and get trained. There's lots of people who are now doing the training and are able to train you. And it's certainly something that you need to do. And the second thing is you need to have the right equipment. You need to have the right instruments, because if you're just going to use what you have and then you're going to try it, you are going to struggle. But by the same token, remember, sorry, Dennis,
go ahead.
Remember one thing, that when you started dentistry, it took you 3 hours to get through the enamel on your first amalgam. Okay. Everything, and the more you did it, the better you became.
It takes me 5 now. But I do it very carefully. I think one of the important things to still talk about, technique is obviously a major piece, and the degree of difficulty of any technique and reproducibility. But the wound healing between the gap, I think we should go back to that. I think there's my biggest concern, if I have one, of doing it, besides teaching it and all that. That's there. If it's good, you're going to teach it, and we are. But the gap distance and what's up against the implant with the socket shield. What gap distance allows bone to fill in front of your implant versus cementum and potentially fibrous tissue? And what happens if the implant is touching it? Like you said, even with a minimum gap that you can't put a bone graft in, which is rare, but it might be. What happens if you leave a piece of tooth there? It's even smaller. I'm not up against the buccal plate, but you could be up against the root shield. So by putting the implant right against it, then like Hertzler's article and some of yours have shown, you don't even have anything in there. You're right up against the threads of the implant, or right up against the root fragment. Now, will that come back to hurt you in 5 years or 10 years? I don't know. What if you have cementum up in the front of the implant instead of bone? Because if you have a small distance, it's going to fill with cementum. If you have a bigger distance, you'll have bone and cementum. See, the people don't realize the wound healing. It's really a wound healing discussion. Can I take about 2 minutes here?
Yeah, sure.
This is critical. People don't get this because they don't understand what do you get cementum there? Where's the cementum? How come you don't get it or something? Okay. When if you take a tooth out, any socket, if this is the socket, I don't know if this shows, if you got this socket, and that's your socket, if all the walls are there, and that's all we're talking about, when all the walls are there, bone will fill into the socket, and it comes from the sides, and the epithelium and connective tissue at the top are the closest cells that could come down, but they don't come down because the cells from the bone coming out of the granulation tissue pre-coated to form bone comes out and fills up the clot, replaces the clot. And so a typical extraction socket fills with bone. Now, if you put an implant in, which is what we're doing with either technique, we just put an implant in. It's really the same wound healing, but with an implant stuck in the middle. That's why gap distance doesn't matter, as long as they keep the epithelium and fibrous tissue at the edge. It will be blocked. It can't come across because the granulation tissue has to support the blood supply across it. Okay, now if you leave a piece of root in there, which is what happens with the socket shield, you have another cell that can fill in the area, and instead of having 3 cell types, meaning bone filling the sides or epithelium or connective tissue from the top, which is not going to move because it's at the top. It can't come across because they've got to wait for blood supply. The clot can't hold it. But if you put a piece of tooth in there and leave that in there, like in here, if that's a piece of tooth, if this is a piece of tooth that you left in there, you don't mind if I get this wet, do you?
Yeah, we got plenty.
Got more of those.
Okay.
Where that came from.
And you can see it on camera too. I got more membrane too. So.
It's called the dental guys.
Yeah, that's right.
So if you now you have another cell that can fill into this area. And what is it? You have the periodontal ligament, the leftover piece of root that you cut, wherever it is, has ligament at the little 1/4 millimeter space, has a ligament. Ligament is fast growing, and ligament is faster than bone. Ligament is within 7 days that'll fill up the gap. So what happens is that the cementum, cementum comes from this ligament cells, and this ligament comes around the back end, and will cover the back of the root shield. So that's what's on the back side. Bone is slow. Bone is the slowest one out of the two, and that way it doesn't get to the back of this. If you got bone touching the root shape first, it's good though. You want to know why? If bone touched it first, you get ankylosis, and you get resorption of that piece of root shield. So it's good that this is almost the body's protective mechanism of cementogenesis coming around the back and preventing the bone from causing resorption. That's good. But at the same time, if you have a close distance, here's the implant. If you have a close distance to that, you might not have any bone. You'll have cementum at best right between it. More distance, which is great, then you get cementum on the back of your root, but your bone can have the time to come across with a bigger gap. And so what's up against the implant is still open to discussion. I think Howard might agree with me on that. And in terms of, it depends on how, I ask you this. What's your ideal gap distance? Tell me that research that shows that what's your ideal gap distance and what's been proven that is shown when you get bone on the front of the implant instead of like Marcus has shown fibrous tissue or connective tissue.
Yeah, you've got a few minutes to kind of counterpoint that. I think you're showing beveling now, and you mentioned some dimension there of a 0.5 millimeter in some situations. And basically, what we're talking about is blood supply.
Well, I think the interesting thing is that where I would disagree with Dennis is that I understand the argument, but the interesting part is that the histology that we have, both animal and human, don't show that. They don't show any cementum. They're showing only bone formation, and they're showing ankylosis. And even the cases where there are, where we've got the inadvertent socket shields, I think there's 2 or 3 articles of inadvertent socket shields. All of them are showing ankylosis and integration. So,
the implant's integrating. That's not what I'm talking about. I'm talking about what's up against the implant.
And if you look at the tooth interface, you've got ankylosis. With regards to the distance, what was interesting was that Hertzler and Danny Baumer's articles were the 2 animal histologies. One they used Emdogain, the other one they did not use Emdogain. When they used Emdogain, that's when they got cementum formation. Okay, was because of the use of Emdogain. The minute they changed and they stopped using Emdogain, then they only got bone. With regards to the width, you can see from the histology where they've sectioned the root that the tooth itself, the implant itself, was in contact with the root. So there wasn't a big jump gap. It was in contact. You can actually see
threads were touching it.
The threads were touching. That's right. And they actually resorbed away. And where it resorbed, you could actually see bone had filled in on that. If you look at the human histology, okay, which comes from Greece, they show exactly the same thing where you've got the part touching. Now, the research that we've done and the research that's coming, and we've got some new prospective studies which are in working, where we're starting to look at all those factors that you mentioned, because I totally agree with you. They're so important that we cover all the bases on all of that, so we can tick the boxes and make sure that there's no ambiguity in what we're talking about. The reason that we are saying pull the implant away from the root is not for the reason that we are worried that bone is not going to form inside there. What it does do, it allows us to put bone in a dual zone therapy style, number one, which we agree will then help to stabilize the clot, make sure that you don't get soft tissue infiltration. And the second thing that's very important is that we're actually trying to reduce the internal shield exposure at the top, because by moving the implant away from the shield, you've got much more space for soft tissue to cover the occlusal portion of the shield, which will then reduce the complication, which our 128 case study in Journal of Clinical Implant Research showed was the biggest complication that we had. Right. So that was the rationale for that.
Let's just have to stop with one thing. The bone up against the implant has nothing to do with putting a bone graft in. That's a big misnomer around the world today. And people think that if I put a bone graft in and stick it in real hard to any gap, even with the dual zone, they think that between the bone and the implant, you stick the graft in there. That graft does not change what's up against the implant. It's as if you still have a clot. It just has particles in it. That graft is strictly to prevent, just like the shield does, collapse when the buccal bone does go through modification or change, remodeling from the extraction, that it prevents the collapse in facially of the ridge. So that's the graft is to keep space. It is not to change what's up against the implant. This is the biggest misnomer out there. In fact, if you look at all histology with the graft in place, every one of them is without shield or no shield. The graft, as hard as you might pack it into the gap, like a dual zone or anything else, the bone, after you see the healing, is never touching the implant after healing. The new bone comes in with granulation tissue from the side, and it pushes the graft particles all over the place, and they tumble them over inside the clot, and the bone graft actually almost gets in the way, but they just keep tumbling, and up against the implant you got the bone or marrow, but you never touches the particles are never touching the implant after healing. It's one of the most amazing things with wound healing, but that's what happens.
Both of these techniques are designed to do some type of custom tissue former design with subcritical contouring, and both techniques utilize either immediate temporization in some way, because these are, exactly what we're trying to do is we're trying to stop this volume change. And I think you both have explained it amazingly.
Yeah.
And there's more to learn, right?
I know.
More to learn.
I know. I wish we had more time, because there's still some great questions that I think we get about how different implant designs even can be used to influence both of the way these techniques work. Even the, talking about how much gap distance do we want to have in order to maximize the ability to place bone into the gap? Does
the implant type matter, John? I mean, we didn't really get into that.
That's.
I got like 59 seconds left.
I know. I mean, maybe can we get a quick take on that? Do we think that the implant design matters?
As long as you have some gap, especially with the shield, it really won't matter as long as you have some gap. Without the shield, and you just do the dual zone, I think the more gap you have, the more zone of bone on the front can heal. So a coax implant or just one place to the palate. I'll go on record as saying this though, and we need to look at this. I don't know if I mentioned this to you, but I think that the place for making sure that you do a socket shield, okay, obviously I mostly don't do them, but I do them. I have done them, of course, in my office. But where is the ideal place for it is where the tooth that you're going to take out and you see the x-ray and you probe it, it's an intact buccal tissue, but the bone is halfway up the tooth, like a prominent cuspid or a prominent central. And you have a dehiscence defect right there of bone. But you have attachment. You have beautiful cementum on there and beautiful ligament. But by taking that tooth out, I'll now have a type 2 defect. I don't have a buccal plate. Why not that's an ideal place for socket shield. Leave it in, and that way the buccal bone there's no buccal bone there to begin with, but the whole shape of the tissue won't change. It's probably one of the most ideal places to show that you might want to do it. What do you think about that, Howard?
I think I understand where you're going with that. Up until now, we've totally contraindicated that as an option. I see we're out of time, so I'll be very quick.
Real quick,
we've totally called that a contraindication, and we've only dealt with type 1 sockets. But I think one could modify the technique where you extend the shield where bone is more interproximally than what you're saying. But one of the reasons why we didn't, to finish off quickly, was that if you do that and there's not enough bone, you could get a loose shield. And if you get a loose shield, then you could get infection and it has to come out. But I think it's great what you say. If we extend it, it might be an option.
Right. Extend it apically and down, as long as you get the apex out.
I love the concept.
Right.
That
way you never create a type 2 defect. It's
right.
Even though it's sitting there, it's healthy, and the root is healthy, and that's what it means.
Wow. Well, this has been an excellent conversation. Thank you guys both again for bringing your insight and having a great spirited discussion about pros and cons and what might work when and where and how. And it's been fun. So thank you guys very much.
Yeah, Dr. Tarnow, Dr. Gluckman, thank you so much.
Well, we're back to recap that a little bit. And wow, I think you now understand. If you weren't a listener at the time and didn't get that as a live stream right away or have not heard that interview, I think it was as good as it gets as far as having two of the top minds in implant dentistry with some very differing opinions, but yet some agreement on some things that I think I was surprised by. And I think, Wes, coming into this discussion or debate, I think my questions, as you saw us ask, were, is dual zone proven? And is socket shield doable by the average clinician? And I think those were some really good points that both of them brought out about, first of all, what's really going on with socket shield, what's really happening, and what are the complications. But then also, too, how technique sensitive really is it in whose hands? And Wes, I was really
the thing.
taken by that.
Yeah, that's the thing, is the amount of qualification to do each of these procedures. As you listen to this, you're thinking, man, there's more to it than just like saying, hey, this is what I'm going to do from here on out. It's like, does this hammer fit this nail scenario? And we want to make sure that you guys understand that where we in the past have had a real problem accepting socket shield as a true treatment option. And a lot of clinicians fall back to dual zone because in some ways it is a good way to get into immediate extraction, immediate placement, especially in the posterior. But as we kind of listen to this discussion back in 2022, a lot of it still resonates. We are really rewriting Frank Spear's article, Ponics versus Implants. If what Dr. Tarnow talks about in there is one of the main advantages of socket shield is if we can preserve some of these root shapes through the mesial to preserve papilla, because that's everything, right? When we take a tooth out, we lose papilla. This is where socket shield could be advantageous. And I'm interested, John, in maybe following up to see where we're at 2 years later. Yep. I know that Dr. Tarnow has changed some of the things he's doing in dual zone in the last 2 years, as we've seen something in some things in the literature regarding the types of cancellous or cortical bone. Where do we use that in the grafting process of the dual zone technique?
And also there still is this huge camp that is still talking about connective tissue grafting at the time of
dual zone
placement of the implant. And do we do that along with dual zone? Do we do that all the time, no matter what? What about alloderm? And this is, when last I was out talking to Greg Kinzer at Spear Education just a few weeks back, I was asking some questions about that. And Jim Janikowski, who is the periodontist that they've worked with for years, who's teaching at Spear, is still an advocate of doing a connective tissue graft every single time.
And I think Gluckman said that in this interview. He said, in addition to dual zone, I do a free gingival graft.
Right.
Which Tarnow disagrees with.
Right, exactly. And I think the connective tissue graft, as I think we know, is one of the few things that looks better over time in dentistry, as opposed to some other techniques which may or may not look as good at 5 years out. Connective tissue grafts are very, very stable. So I think that what we got from this was a ton of great information. I think they were the right questions were hopefully asked by us, and some great questions asked of each other. And that's what we're going to try to do as we go back to this year's AO, is try to encourage these same discussions and hopefully, like Wes said, get some updates. Now, if you have questions for our speakers that are going to be with us at AO, now you might not know who all those speakers are going to be right now. We're going to be announcing those prior to the meeting. But as you learn more about them, we want you to tell us what questions you want us to ask. That's right. You can become interactive with the dental guys at the AO with some of the best speakers in implant dentistry. And if you text us at 865-544-8954, that's 865-544-8954, we will be able to see your questions, and potentially your questions could become a part of the show.
Just like tonight, John, we're going to talk about one of those comments from back in episode, I think it was 151, where we were talking about composite bevels. And I talked a little bit about the star bevel. I had one of our listeners, Alan, shout out to Alan, longtime friend of the podcast. And he said, "This is Alan. You guys sound and look great. Some folks recommend a very wide enamel bevel. where you place your composite past the bevel. It requires some kind of biofilm removal prior to bonding. Alan goes on to say it's David Clark's BioClear take. Quote, where's the margin? Don't know and don't care. He calls it the infinity margin. Alan says he's used this concept with some success, and I've used this concept with success, and I should say that. So, thanks, Alan, for the comment about his take on the bevel. David Clark does have an interesting take on that, and this is great. So this is what we're all about here, right? So is you guys text us, and your text might get mentioned on the next show, The Dental Guys. So give us a text, 1-865-544-8954. Text your comments, questions, and maybe your suggestions to The Dental Guys. I'm super excited about the AO. It's March 7th through the 9th. If you guys haven't got signed up yet, there's still time. It's in Charlotte, North Carolina. We will be there in full effect. I really want to thank our sponsor of this episode, the Dental Crafters Network, and John and I have been longtime users even before the podcast launched of the Dental Crafters Network. Truly a family-oriented business where we see the results of their expertise in the things that we do day in and day out. I'll say this about what my associate said in the past. He was coming from another office, and he said, it's like another world whenever I stepped into your office and was able to use a high-quality lab that's helping me become a better dentist. And this is what the Dental Crafters Network is all about, is helping you achieve what's possible. And we're excited about the Dental Crafters Network this year and some of the things coming up with them as we collaborate with our sponsors. John, it's been another great episode of the Dental Guys. Super excited about what's to come.
That's right. And make sure, once again, if you haven't registered for the AO meeting, get on that website, osseo.org, and register. Of course, like, share, and subscribe. Let your friends, let your colleagues know about what the Dental Guys are doing for you in your practice, and get them on board with us, because we're going to have an exciting year. Thanks for listening.